Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Open Forum on Acute Disseminated Encephalomyelitis. My name is Gigi DeFibri, and I will be moderating this podcast. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. We want to thank the sponsor of this month's podcast, Alexion. Alexion is a global biopharmaceutical company focused on serving patients with severe and rare disorders through the innovation, development, and commercialization of life-transforming therapeutic products. Their goal to deliver medical breakthroughs where none currently exist is driven by the knowledge that people's lives depend on their work. For today's podcast, we are pleased to be joined by Dr. Arun Venkatesan and Dr. Cynthia Wang. Dr. Arun Venkatesan is an associate professor at the Johns Hopkins University School of Medicine in the Department of Neurology, Division of Neuroimmunology and Neuroinfectious Diseases. He received his undergraduate degree in biomedical engineering from the University of California, Berkeley in 1994, followed by a PhD in microbiology and immunology, and an MD from the University of California, Los Angeles. He continued his medical training as an intern in medicine at Santa Clara Valley County Hospital, followed by a residency in neurology at Johns Hopkins Hospital. Following a fellowship in neuroimmunology and neuroinfectious diseases, he joined the neurology department and is the director of the Johns Hopkins Encephalitis Center, where he oversees clinical and research activities. He is also an active member of the Multiple Sclerosis and Transverse Myelitis Centers at Johns Hopkins. His current research focuses on the pathogenesis of infectious and autoimmune conditions that affect the central nervous system. Dr. Cynthia Wang is an autoimmune neurology fellow at University of Texas Southwestern Medical Center, supported by the TMA's James T. Lubin Clinician Scientist Fellowship Award. She completed a pediatric neurology residency at the University of Michigan, where she developed interest in rare neuroimmunological disorders in children. Her fellowship training thus far has involved seeing adult and pediatric patients with TM, ADEM, NMO, ON with Dr. Benjamin Greenberg and his team. Her primary research interest is in immune-mediated and demyelinating central nervous system conditions in children, particularly ADEM. Her current research project involves studying the long-term neuropsychological and quality of life outcomes in ADEM. So welcome both of you, and thank you very much for joining us today.
Thanks so much, Gigi and the TMA.
So just to start, if you just give a little bit of an overview about what acute disseminated encephalomyelitis is, and what the presenting features are and how it's diagnosed. Dr. Wang, if you could start.
Sure. Yeah. Thanks again for inviting me. And certainly I have the honor of completing my fellowship with the generous support of the TMA. So I'm very happy to be here on a topic that's of personal and scientific interest to me. So ADEM, or acute disseminated encephalomyelitis, is a rare autoimmune disorder typically affecting the brain and the spinal cord. It's seen mostly in young children, ages 5 to 8, but certainly can happen in adults too, because ADEM can affect multiple parts of the nervous system. The manifestation can be quite variable and can be things like headaches, neck stiffness, fever, and then become things like confusion and decreased level of alertness, lethargy, weakness. Our understanding of ADEM is still incomplete, but in many cases, ADEM is preceded by an infection of a viral or bacterial infection in about 3/4 of the cases. So we think that that infection may trigger some sort of a dysfunctional immune response that causes injury in the central nervous system. I might just pause there and see if Dr. Venkatesan has anything to add.
Cynthia, I think that was a really nice summary. The only other thing I might add at this time is that typically ADEM is considered a monophasic disorder, meaning a disorder that occurs once. Very rarely would it potentially recur, and that's one of the distinguishing features between ADEM and related conditions that are also immune-mediated and that can affect the myelin in the central nervous system, such as multiple sclerosis.
And so you mentioned, that it's usually monophasic. So are there any other criteria that is used to diagnose ADEM? And is there a difference between diagnosing pediatric ADEM versus adult ADEM?
So I would say that ADEM is typically a disorder of children. So the vast majority of cases of ADEM occur in children under the age of 10. And that's where most of our knowledge of ADEM actually comes from. And so what we've learned from pediatric ADEM, we typically abstract to adult ADEM as well, although there may be some subtle differences, and Cynthia might comment on that in a bit. In terms of diagnosing the disorder, it's typically a process in which there is a lot of inflammation that occurs at the same time. And so one would expect that symptoms evolve quickly over the course of a few days, and on imaging that there are signatures that suggest that the multiple lesions that one sees on brain MRI all arose around the same time. And that's really important for us clinicians in evaluating a patient with suspected ADEM. When we see an MRI in which we see lesions that appear to have arisen at different points in time, for example, we're evaluating a patient with acute symptoms, and on MRI, they have new lesions, but they also have lesions that look like they originated previously, months or years previously, then that really raises a red flag for ADEM, because it suggests that we're dealing with one of these chronic or recurrent demyelinating disorders. So again, acute symptomatology, MRI that shows lesions that occur around the same time, and a lumbar puncture that typically doesn't show some of the signatures that we see in conditions like multiple sclerosis. So in multiple sclerosis, or MS, we have a test called oligoclonal bands, which essentially is a demonstration of antibodies that are present in the central nervous system that are not present in the blood. Oligoclonal bands are present in the vast majority of patients with MS and are very rarely present in patients with ADEM. So that's another way in which we can prognosticate when we see a patient as to whether they're more likely to have ADEM or more likely to have one of these chronic demyelinating disorders.
Great, thank you. That's a really good overview. And Dr. Wang, do you have anything to add in terms of the differences between pediatric and adult ADEM, or in terms of diagnosis?
Yeah, that's a good question. I think there are subtle differences, but for the most part, what we see has a lot of overlap. The International Pediatric Multiple Sclerosis Working Group actually set out definitions for ADEM. I think most recently updated a few years ago, but with the most recent update, they included the presence of encephalopathy, which is kind of a fancy term meaning just kind of altered consciousness, altered awareness, some sort of change in, the child or adult's functioning. They included that, and they found that the sensitivity of adding that was great. So by adding that, encephalopathy excluded a lot of people who may later on be manifest as having multiple sclerosis. I don't think that encephalopathy distinction exists as much in the adult literature, and they can have multiple deficits, but not necessarily have that amount of confusion, or it's not as as I think easily visible for adults. But certainly when a child comes in with lethargy, extreme irritability, that kind of raises the flag that this is a fulminant or just a very rapid and significant change in their baseline that is suggestive of ADEM.
I think that's, just to add on to that, I think that's a great point that, Cynthia, you just made about the encephalopathy, or the change in consciousness or behavior of a patient. Even in adults, although, as you point out, it may not be quite as common as it is in pediatric ADEM, in adults who come in with an acute demyelinating disease, if there is an encephalopathy, then that really does raise the stakes for the diagnosis of ADEM.
Mm-hmm. Yeah, I think that's a good point because, like you mentioned, ADEM is more common in pediatrics. When it gets to be more adult age patients, we get concerned about the chronic relapsing diseases like multiple sclerosis. And we know multiple sclerosis can present with multiple deficits, but they typically do not have that confusion or behavior change that we see in ADEM.
Great, thank you both. And then Dr. Venkateshan, you did mention about, MS. We did get a question about, someone was asking if ADEM was linked to NMO or neuromyelitis optica, because their daughter was, had ADEM in 2001 and last year was diagnosed with NMO.
Yeah. So this question comes up a lot, mainly because, we're still getting a good sense for the natural history of these demyelinating disorders, and we're still in the process of developing specific markers for the various demyelinating disorders of the central nervous system. And so examples of these demyelinating disorders include ADEM, as we've discussed, multiple sclerosis, neuromyelitis optica, which is another demyelinating disorder of the central nervous system that typically affects the spine and the optic nerves, and others. And so when we are faced with the initial inflammatory disorder in a patient, we're often not certain whether this is going to be monophasic and therefore ADEM, or whether this is going to transition into one of the more chronic demyelinating disorders, such as MS or NMO. I've talked a little bit about some of the, for example, spinal fluid signatures in multiple sclerosis. We're still, the field is still working on more specific and sensitive biomarkers in MS. But for now, MS really is a clinical disorder that's supported by MRI and sometimes by spinal fluid findings. There's not a single test that actually cinches the diagnosis of multiple sclerosis. And so when a patient comes in with that first attack of immune-mediated demyelination, oftentimes we have to wait and see how the process unfolds before we can understand whether this was ADEM or MS. The situation's a little bit different for this other condition, neuromyelitis optica or NMO, where we tend to have better blood-based biomarkers for the disease. And so what most of us do at this point when we see a patient with suspected ADEM is that we'll go ahead and screen for NMO, and we can do that with a relatively simple blood test, or now actually 2 blood tests that can identify several different biomarkers.
Okay, great, thank you. And then moving on to questions about symptoms, someone asked me that their son had ADEM 5 years ago, and one of his initial symptoms was his eyes were hurting and that he was having headaches, and that he still has headaches quite often. Is this a common ongoing symptom, or is it usually just at the presentation?
I can start with that one. Yeah, I think headaches in particular is, a complaint that many people have. Just, it's a frequent neurological symptom, but certainly when it overlaps with something that a child came in with as an initial symptom of ADEM, it can be quite anxiety producing. I guess my approach in terms of first answering that question or exploring that question, is this just a result of the history of ADEM, which is, kind of a neurological insult on the brain that can maybe predispose a child to, having more headaches just because the brain's not functioning at it the way it used to, or is it a recurrent attack? Is it, is this another marker that may be concerning for new inflammation? So I think once you answer that question, and if there's not concern about new inflammation, or you do tests to rule out that there's no, MRI findings or findings of new inflammation, I think you can kind of approach it more from the symptom management perspective. One thing I encourage my patients to do is to keep a headache diary. I think a lot of the process of treating headaches is to identify the triggers of the headache. So if someone, is not routinely getting enough sleep, not hydrating enough, not eating regular meals, that can certainly predispose them to headaches. We know stress, anybody can have stressful situations that can bring on a headache. So if we can avoid those triggers, that can be a powerful way to reduce headaches. If the headaches become more debilitating and, say affect the child's ability to attend school, then it may be advisable for the family to talk to their physician or neurologist about whether medications would be helpful to prevent headaches from coming on. And that can be, over-the-counter methods such as vitamins and supplements like magnesium and riboflavin, or it can be more prescription geared medications that can be in multiple classes, such as anti-epileptics and blood pressure medications. So I think getting a good sense first of how frequent the headaches is, how debilitating they are, that can be a good way to approach the medical provider on the best way to treat them.
That's a really nice approach, Cynthia, that you outlined. Just want to add a couple of things, which are, certainly headaches are not an uncommon aspect of the acute presentation of ADEM for a couple of reasons. One, there can be some inflammation of the meninges, the covering around the brain, if it's right next to one of these inflammatory lesions, which can sometimes happen. And certainly in the setting of meningeal irritation, one can get headaches. Alternatively, there can be lesions in portions of the brain that can actually result in acute headaches as well. So, from that standpoint, it's not uncommon to have headaches as an initial presentation of ADEM. And then in terms of headaches following encephalitis, for example, at our encephalitis center, we follow a number of patients, and headaches are one of the most common complaints amongst those who have had an episode of encephalitis, whether it is ADEM or an infectious encephalitis, or even one of the other autoimmune encephalitides. And as Cynthia mentioned, we don't quite understand exactly why that's the case, why after an acute inflammatory injury, one might be more predisposed to getting a recurrent or chronic headache syndrome. But I think, she very nicely kind of outlined an approach to be able to help patients with some of these chronic headaches.
Great. And then, other than headaches, what are the ongoing symptoms that someone might deal with as a result of having ADEM, and what's the long-term prognosis?
Cynthia, take a stab at that.
I can take a stab at that. Yeah. Again, since ADEM is multifocal and can have lesions in various parts of the brain, I think the prognosis depends where the inflammation was. So, some kids have inflammation that can involve their spinal cord, and that can lead to transient weakness that hopefully improves over time, but still that can lead to some residual deficits that don't go away in terms of strength or coordination. Since it's often a brain-based disorder, we can see more subtle deficits in cognition. So in terms of processing speed, short-term memory, inhibition of behaviors, impulse control, attention, those kind of domains. So I think it depends partly where in the nervous system the ADEM affected. And then we kind of judge the prognosis based on the recovery course. So if a child does well in the beginning and seems to return to much of his or her normal function, that usually portends a pretty good prognosis. But I think as we're starting to discover, when we look more closely and ask the right questions in terms of more subtle cognitive deficits, we do uncover residual deficits that may manifest over time, especially as a child gets older and has increasing academic demands and social demands.
I would agree with that. I think I would echo that, overall ADEM is actually considered to have a really good prognosis. Part of that is that, the majority of patients who are affected are children, and that there is an amazing capacity in many children for plasticity and for rearrangement of the nervous system after injury, such that there can be really significant recovery. The flip side of it, though, is that it's are cognitive, sequelae from ADEM, and it's probably underappreciated how significant this is, because I think in the past we haven't really asked the right questions about how impaired somebody might be, how impaired functionally and cognitively a patient might be. Oftentimes physicians who aren't as nuanced in terms of their understanding or treatment of ADEM, if they see that a patient came in unconscious and not moving anything, and they leave the hospital being able to speak and being able to move, well, that means full recovery. That's certainly not the case. Many patients with ADEM, as well as with other acute encephalitides, are left with cognitive deficits that can actually pretty significantly impair their ability to going back to leading the full lives that they had prior to their injury.
Yeah. Thank you. So, Dr. Wayne, did you have anything else?
No, I completely agree with that. And I think, part of the difficulty in studying ADEM is that since our thought is that kids do well, there's not a lot of follow-up. It kind of takes specific groups asking the questions over a sustained period of time to really uncover those answers. And I know in our group, Dr. Lana Harder, who's a neuropsychologist, has observed that over time, there may be a sort of a growing into process where, kids who get ADEM as a young child, they're not expected to do as much in terms of their cognition and speech, but when they get to a certain level where school becomes more challenging, or their attention needs to be more refined to be able to function at the way that their peers do, we really start to see those problems. So in our clinic, our approach is to follow kids for a sustained amount of time, even if it's intermittently, such as once a year, just to get a sense of, if any difficulties occur over time, and if there's ways we can support that through accommodations at school.
And I would say that approach is just so important, because one of the major gaps in our understanding at this point really is in terms of the long-term cognitive outcomes in ADEM, and the only way to really get a sense for that is to do what you guys are doing, which is to follow patients over time in a careful way in order to be able to get that understanding.
Great. And then we did get a question about the epidemiology of ADEM in the US. So do we know how many people get ADEM every year? How many of them are children versus adults? And is there any difference in terms of the epidemiology for viral caused ADEM versus not?
I can talk about the pediatric. I think I'm a little less familiar with the adult epidemiology, but I think in a couple studies, the incidence was something like 4 to 8 in a million, something similar to that. So it's quite rare. And then in terms of it following an infection, it's been as high as, I think, 75%. So I definitely think there's some sort of link between having infection in the month preceding the attack of the ADEM. And historically, there was concern about immunizations. I'm a little more skeptical about that data, and I think more refined studies have looked, and I think the incidence is quite low. It's really hard to kind of disentangle that, because as children get vaccinations so frequently, and they can get infections so frequently. But in the studies I've looked at, incidence of ADEM following infection versus following a vaccination, it's many folds higher that ADEM develops after infection than a vaccination.
Yeah, and the incidence in adults is about 5 to 10-fold lower than in children. So it is a fairly rare disorder, but one that that can certainly exact a fair amount of morbidity and can cause cognitive dysfunction, and for which we really just need to learn more about.
Mm-hmm. And then we did get a question asking if there's anything on the horizon to at least treat the symptoms, like pain or stiffness or incontinence. Dr. Wayne, do you know of anything?
Yeah, again, I think first just parsing out whether the symptoms are related to residual symptoms, so if they're pain, stiffness, and similar areas that maybe the initial attack of ADEM occurred in, then it's most likely because the body's under some sort of physiological stress, and because of having had an insult in the past, it's just not as well equipped to kind of deal with that. So first ruling out any infections that could be contributing to the symptoms, and then again, really careful history taking, what causes the pain. Is the pain more of a neuropathic sort, in which there may be a burning or electrical sensation, which comes from, injury of the nerves and they're just not firing or processing information in the correct way? That can be treated fairly effectively with medications such as Neurontin, Lyrica, Cymbalta. But pain can be more nuanced and result from other things like stiffness, like the participant mentioned, muscle stiffness or spasticity, spasms. Those can certainly be very painful, and that could respond better to treatments such as muscle relaxants, such as baclofen and tizanidine, Flexeril. And then something we see as a result, especially in our TM population, is that weakness can cause all kinds of mechanical issues where a child may be placing, more stress on joints that weren't, they weren't built to really manage that type of stress. And those issues can lead to joint pains, and that may be better treated by, non-inflammatory NSAIDs or inflammatory medications such as that. And I think, what was the last thing? Bowel dysfunction. That's unfortunately one of the, I think, most residual and long-lasting symptoms that may never completely get better, but I think just making sure that there's not a coexistent urinary tract infection that could be causing worsening urinary function is important. If there's any acute decompensation in urinary function, and then in some cases, an individual may still have kind of poor emptying or incomplete emptying, and just having that issue may require things like catheterization. But over time, it usually improves. So it may be talking to the neurologist, the physiatrist, or a urologist, and trying to best manage those symptoms.
And just to add to that, I think you're absolutely right. So spasticity is, can be a huge problem in patients who have suffered from central nervous system inflammation and demyelination, whether that is in the brain or in the spinal cord. And you mentioned some treatment options. One of the other options, if that stiffness and pain is more focal, if it's, for example, just one leg, an arm, would be botulinum toxin or Botox, which has turned out to be quite effective for focal stiffness and sensitivity and the pain that's associated with that. There's also a fair amount of interest in trying to understand whether newer medications can be effective. For example, cannabinoids are now being actively investigated. So these are compounds that are found in marijuana that can be extracted and purified, or potentially even synthesized in the lab, that may have specific effects on receptors in the nervous system that could potentially modulate spasticity or pain. And a number of studies have suggested that, at least from a patient perspective, that there's subjective improvements in measures like spasticity and pain with cannabinoids. And so now the question is, are we going to be able to find objective improvements that we can actually track and follow over time? That's just one example of newer medications that are being brought to bear to the problem of pain and spasticity following ADEM.
Yeah, Dr. Venkatasan, that's a great point. It's certainly a question that comes up a lot in our patient population. And, I think we as clinicians and like people in the medical community, we don't study things, alternative and complementary approaches. So, there's a huge emphasis on studying, how the mind interprets pain. So some things I've recommended to patients is thinking about other techniques such as biofeedback or acupuncture, certainly done by somebody who's qualified to do those things, and at the recommendation of your medical provider. But just if medications are too sedating or cause too many intolerable side effects, then to maybe talk to your provider about things that are not pharmacological that may be beneficial. For spasticity, I think somebody having a very regular stretching routine is critical. So there's a lot of different ways, and all of them sort of add up. So you can use multiple approaches to really get symptoms under better control.
Yeah, it's a great point.
Thank you both. And so, Dr. Venkatesan, I know earlier you said that ADEM is usually monophasic. We did get a question, though, from someone who said they have a child with multiphasic ADEM, and they wanted to know if there's any relevant treatment known for in between the attacks, to prevent them or moderate them, or maybe just make the immune system work correctly.
Yeah, it's a good question. I think one of the things that we really need to be clear on is how extensive of an evaluation has been performed in order to try to understand whether there is some other condition at play. And what I mean by that is that, could there be some other chronic demyelinating condition, whether it's neuromyelitis optica or MS or one of these other conditions? Could there be for example, systemic autoimmune condition, lupus or Sjogren's syndrome, Behçet's, for example, that can result in recurrent central nervous system inflammation? Or even could there be a chronic infection that might periodically erupt? And so I think, before really putting my dime down on recurrent ADEM, I would need to be very certain that all of these other conditions have been reasonably ruled out. If that's the case, if there's been an extensive for these other conditions that can result in recurrent central nervous system inflammation and nothing's turned up, and this really does look like it's an autoimmune process that's affecting the nervous system, typically after the second episode, I would probably place a patient on an immune suppressive medication. I say probably because a lot of this depends on the patient, on the family, on the age of the patient, and on the perspectives of the patient and family towards chronic medication, side effects, and so on. And so I would at least have that discussion with the patient and family regarding potential benefits and side effects of that approach. And then together with the patient and family, make an informed decision about how to proceed. Now, if there's then a third episode of central nervous system inflammation in the absence of treatment, I think that really does tip the scales towards being a little bit more aggressive in terms of treating with immune suppression or immune modulation.
Mm-hmm. Yeah, I definitely agree. That's really the approach. I think with a second attack, it's a bit more of a discussion with the family, but at the third time, it's a pretty good signal or indication that the immune system is dysfunctional and can would love to potentially wreak more havoc and cause inflammation if it could. I guess I would just step back and also define, some people may not be familiar with what multiphasic ADEM is, defined by, I guess, the medical community as, and that is kind of a second event that fit the criteria for ADEM that occurs after 3 months. A practice that we've started doing more commonly is just getting a baseline MRI of a patient sometime after that 3-month period, just to know sort of what the brain looks like at that point. And then if there were any future symptoms concerning for another attack, we could repeat the imaging. And if there are new lesions that argues against certainly the classical monophasic form of ADEM, and should maybe raise questions and lead to further testing, like Dr. Venkatesan said, about alternate causes of a relapsing inflammatory disorder.
And I would add that I completely agree. Getting that post-acute baseline MRI is actually really critical, so that one has a good point of comparison for anything that might happen in the future. And we tend to do that in all of our patients with an acute encephalitis, because things can change in the acute period in terms of the MRI. And so, what appeared on the very first MRI when a patient comes into the hospital may actually be very different from the appearance of the MRI when they're discharged from the hospital. And for that reason, we agree. We think it's really important to get that post-acute baseline MRI scan of the brain.
Okay. And relatedly, how there's certain follow-ups that people should be doing with their doctors and like MRIs over time. How often and how long after onset?
I think in the pediatric population, it depends. Certainly like to get that baseline comparison after 3 or 4 months. But then after that, it depends on, in part, the age of the child. In children, it's a little more, I guess you could say risky, but just that they would need sort of general sedation, just because a child really can't be expected to hold still for an hour-long study, or however it may take to do a study like that. So I think in our younger population, we kind of lean more on the parents letting us know if there's a change in the child's functional status, and that would prompt getting that study. In an older child, we may screen annually for a few years, just to make sure we don't see someone who can do the study without needing to be sedated. I don't think there's a correct answer in this, and a lot of it may depend on features of the initial presentation. So if there were any kind of oddities to the ADEM presentation that makes us think that maybe this isn't the correct diagnosis, then more frequent surveillance may be indicated.
Yeah, I would agree that a lot of that is dependent on one's evaluation of the patient following the acute episode. And if there's concern for things evolving or changing, then obviously we're much more aggressive about getting more frequent MRIs. In the absence of that, the interval between the acute MRI or post-acute MRI and the next one, it can be 6 months, it can be a year, but essentially you want to do at least 1 or 2 more MRIs over the year or two to ensure that there's stability, that there is not an accrual of new lesions that would suggest that the diagnosis is not ADEM, but rather one of these other chronic demyelinating disorders.
And then, Dr. Wang, do you know of any clinical trials or studies that are available for people with ADEM?
Thank you for asking that, Gigi. I'm actually starting up a project looking at ADEM, in particular, long-term cognitive outcomes and quality of life outcomes at UT Southwestern. It's termed Aperture, or assessment of pediatric and adult encephalomyelitis related outcomes, understand, reveal, educate, sort of paralleling what Capture did for transverse myelitis. We just got the approval at Children's to start enrolling for the study, and I would invite people to look at the TMA website about the study to see if they might be interested. It's not a interventional study, so we wouldn't necessarily, put anybody on any sort of treatments, but really just look at the initial history, the tests that were done, look at how those features of the illness and the treatment that the individual got may relate to how they do, years down the line. So if anyone is interested, there is an email that we're using for that. It's PDConquer, PEDICONQUER at utsouthwestern.edu. If someone were interested, they can email that, and me or another research associate will get back to them. We hope with this study to start to ask the questions of, how things manifest over time, especially with cognitive functioning. And I think there are other studies, probably from many other centers, but I'm just not as informed about them.
Yeah, I would just add that we've been doing something similar here at Johns Hopkins for some time now with all of our patients with encephalitis or encephalomyelitis, where we are capturing them prospectively and then following them over time and assessing them both in terms of cognitive and physical domains in order to get a better understanding of the natural history of the disorder and of outcomes. And it sounds, Cynthia, like there are opportunities where we might actually be able to work together on this to help our patients.
Yeah, absolutely. I think the TMA is about these rare neuroimmunological diseases, and a lot of the time we need multi-center studies to really make significant findings that we can actually interpret into practice.
And then we did get a question too about any stem cell therapies. Are there any potential studies for ADEM with stem cells on the horizon, or have there been studies in the past?
So there are studies ongoing in terms of autologous, meaning taking one's own cells and transplanting them in multiple sclerosis. So taking one's own blood cells and doing a transplant. The studies are still not definitive. I think there's a lot that we still need to understand. But there is some hope that these types of approaches will lead to, for example, better remyelination or recovery following the initial inflammatory demyelinating event. And so I guess I would say there's a lot of interest in these types of approaches that as far as I know, they haven't specifically been applied to ADEM, mainly because it's the population of patients affected by ADEM is quite small. And so investigators have started with disorders in which more people are affected, and it may be easier to recruit patients with those disorders. But at some point, if we are seeing positive signals from some of these other patient populations, then I think there may be an opportunity to translate things to ADEM.
Yeah, I would agree. I think in domains such as transverse myelitis in particular, there's a lot of new studies that may be in the near future about, either using direct injection of stem cells to see if they can help remyelinate, or in MS sort of to use stem cells to sort of ablate the own immune system that might be dysfunctional, and then kind of reboot it and let it restart again into hopefully immune system that isn't as overactive or dysfunctional. I think in ADEM, one has to weigh the potential risks of these invasive procedures versus the functioning of the child. And since so many kids do pretty well, I think there's maybe a larger role for therapy such as neurobehavioral therapy, speech language pathology, other types of therapy that are less invasive and may just allow the natural processes of the brain development to kind of make the right connections over time, rather than introducing something like stem cells.
And then we did get a question about that. So this person's TM or ADEM is believed to have been caused by reactivated VZV or varicella zoster virus, and they're a 43-year-old person, and they were just wondering if there's any recommendations for or against administration of the shingles vaccine when they reach the recommended age.
So I'd be glad to tackle that one. I think that, when I hear a question like that, one of my questions is this really a recurrent, or I'm sorry, was this a relapsing ADEM or a single ADEM?
No, a single ADEM. It seems.
Single ADEM?
Yeah.
My question then is, was this really ADEM? Meaning, was this a, for example, a post-infectious demyelinating process, or was it actually a reactivation of varicella-zoster virus in the nervous system, wherein the virus is directly causing disease? What we know about viruses like varicella-zoster virus, which is the virus that causes chickenpox, as many of you know, is that once you get the virus, it actually remains dormant in the nervous system. It settles in cells called ganglion cells. And during one's lifetime, the virus can actually reactivate, meaning it can escape its dormancy. And the majority of the time that it does that, it actually reactivates out into the skin, and it causes a condition called shingles, which is, as many of you know, very painful, but relatively self-limiting. In the minority of cases, that reactivated virus can go back into the central nervous system, and it can cause, for example, myelitis, it can cause encephalitis or encephalomyelitis, and it can look similar to ADEM. So, one of my questions would be, was this really ADEM, or was this a reactivation of varicella-zoster virus in the central nervous system? And if it was the latter, then it sounds like, the patient was treated with appropriately with acyclovir, and the recommendation would probably be to get the vaccine when appropriate. If, on the other hand, this was a reactivation of the varicella-zoster virus, say in the periphery, that is in the bloodstream of the patient, that then led to an immune-mediated demyelinating attack in the nervous system, ADEM, that is varicella-zoster virus triggering ADEM, that's a completely different ballgame. And I think recommendations about vaccination in that setting are less uniform. It's harder to know what to do about vaccinations in that setting.
Yeah, those are great points. And I think that's a question with a lot of infections. We know ADEM seems to happen in certain times of the year where, people are sick with different viruses and bacteria, and there's not been, certainly any single virus or bacteria that's been implicated, and a variety of things can lead to ADEM. I think this also is important in diseases such as acute flaccid myelitis, which you've covered on previous podcasts, in which there is reason to believe there may be a direct kind of virus injury to the spinal cord. But then we're also exploring whether, an over exuberant immune response may be perpetuating or, worsening that injury. And those questions are kind of the center of research studies that are currently being done.
Right, and we did get, relatedly, we got another question about actually herpes zoster virus, and this person was just wondering, if there's more research on looking at viral causes of ADEM as opposed to bacterial, or not.
So it turns out that it's actually a fairly similar question, because herpes zoster virus is another name for varicella-zoster virus. They're the same virus. There's just different terminologies because varicella-zoster virus is part of the herpes virus family. So it can be known by multiple names. And it just goes back to this point that varicella-zoster virus it's a very interesting virus. It can cause acute encephalitis or encephalomyelitis. It can be multifocal, meaning it can affect various parts of the brain, just like ADEM can. And it can occur either in a monophasic way or in a multiphasic way, meaning it can come back. And so it's just one example of how a virus could mimic ADEM, and there may be other viruses that can do that. I think that the challenge that Cynthia described is that in terms of infectious triggers of ADEM, it really looks like there are many, many possible triggers. And so it may be very difficult to get a more specific understanding as to how a virus or a bacteria even may trigger ADEM. I will tell you that I've seen cases here at Hopkins where I'm fairly certain that it's a bacteria that triggered a patient's very classic ADEM. So I'm certainly open to that possibility. I just don't know if we're going to be able to get more specific information as to how that occurs and how that might inform treatment. Because regardless of whether there is a virus or a bacteria that instigates the ADEM, if this really is a post-infectious demyelination, meaning an immune-mediated demyelination that follows the infection, then the treatment is based on that immune reaction, not necessarily on the virus or bacterium that triggered it.
Right. Okay. And then so we're actually getting towards the end of our time, so I'm going to try to get through some of the remaining questions we've gotten as we've been talking. So we didn't talk a lot about kind of the acute treatments for transverse myelitis, but someone did specifically ask about IVIG and its use in ADEM.
Yeah, I can start. I think you said transverse myelitis, but probably you meant ADEM, but no, that is actually pretty, indicative of sort of our current, unfortunately, somewhat crude way of treating acutely these types of immune-mediated diseases. IV corticosteroids, IVIG, which is kind of pooled antibodies that come from a pool of donors, and then a third therapy called plasmapheresis or plasma exchange, where we basically remove from the blood these potentially pathogenic or disease-causing antibodies. Those are all sort of acute treatments. There's not been enough studies to say that one works better than the other. Our general approach is to kind of go from the least invasive approach to the potentially more invasive, and also depends on sort of the severity of presentation. So it's not uncommon to start with IV corticosteroids just because it can be given through an IV. IVIG and plasma exchange could potentially have more side effects. For IVIG, it can often cause headache or blood pressure changes or renal dysfunction. So it's all about kind of weighing the potential risk of the treatment with how a patient is doing. In terms of, I think that maybe the question was also how does it work? Again, something we're sort of still struggling to fully understand, but we think that perhaps giving more antibodies than a patient normally has may tell the patient's own immune system to sort of calm down and not produce its own antibodies, which may be the more disease-causing type. And in the cases of things like plasma exchange, actually just manually removing the antibodies that could be causing or perpetuating the disease.
Yeah, I think that's a great summary.
And then is there what is the prognosis for someone who had their diagnosis for ADEM come too late? So after 5 to 6 weeks after onset. Dr. Venkatesan, you could get this one.
So the question is, what would their prognosis be if they have had ADEM for 5 or 6 weeks and not have been treated? Is that
right? So the diagnosis came 5 to 6 weeks after the onset. Yeah.
I see. So I think the question gets at how soon do we need to be treating patients with ADEM, and I think experience suggests that the sooner that we treat, the sooner we control the acute inflammation, and potentially the less neurologic injury can occur. Having said that, in ADEM, and we see these patients a lot because patients may not be diagnosed for weeks, maybe at other hospitals, and then they end up getting transferred to Hopkins, and so we see this not uncommonly. We make the diagnosis of ADEM, we begin treatment 5 or 6 weeks after, and there's a good response. So I think that the inflammation in ADEM can certainly persist for weeks. It's why in the criteria for multiphasic ADEM, it's why the stipulation is that you would need to have another attack of neurological disease 3 months out from the first one, because there's a recognition that one can have continued inflammation and fluctuation of disease for the first few months. And while there is acute inflammation going on, there is potential for medications like steroids or IVIG or plasma exchange to help and to have effect. So I would say certainly not all is lost. If the diagnosis is made, 5 or 6 weeks after onset, that certainly we would adopt the same kinds of treatments that we've been talking about, and that there can be improvement.
Mm-hmm. And sometimes when it comes to like a juncture of care where there's, another team reassessing the patient, especially after several weeks, it may be helpful to, repeat studies such as MRI to look for, changes that suggest that there's ongoing inflammation, such as, contrast enhancing lesions, or sample the spinal fluid to see if there's any evidence of inflammation, to see engaged potentially the amount of repair that can be done with, further treatment.
Okay, and then how can someone, I've got a question, how can they be sure that their child's doctors have the most up-to-date information and research in order to care for a child with ADEM? Is there any particular resources or, information that's useful for this?
Yeah, I would say, certainly kind of finding a partnership with a provider. We understand and recognize that this is a rare disease. Somebody may not have access to a neurologist or a neuroimmunologist where they live, but just finding someone who is open-minded and able to, look into the literature and be up to date with new findings. I think something that we didn't talk about that I did want to at least mention is, like Dr. Venkatesan said, we're starting to recognize a different syndrome that is caused by an antibody to something called myelin oligodendrocyte glycoprotein, or MOG, M-O-G. And it can cause, it can manifest initially as ADEM, but be a part of a relapsing illness that can look sometimes similar to neuromyelitis optica syndrome. So probably in the next year or so, we'll be able to test, anyone will be able to send this test and see if a patient has this antibody. And there's some research to suggest that persistent elevations of this antibody may actually fit in more to the category of a relapsing disease, such as MS and NMO. And looking at reputable sources, I think the TMA is an excellent resource. The newsletters really, summarize sort of the ongoing research well. Just looking at those reputable resources and keeping up to date with the medical literature is excellent way, to know what is the newest recommendations for management of ADEM.
And just to add to that, so in terms of the MOG antibody that Cynthia you mentioned, so we're now assessing for that on a research basis here at Johns Hopkins, and like you mentioned, there are plans to commercialize this soon in the United States. In terms of other resources, there are additional resources for patients and families. So I work closely with the Encephalitis Society, which is based out of the UK. They actually pronounce it the Encephalitis Society there. And their website is actually quite a good source of information for patients and families. They have specific information on ADEM there as well.
Mm-hmm. Absolutely.
Great. Well, thank you both so much. We're unfortunately at the end of our time, but we we always like to continue these conversations, and we'll have additional podcasts in the future. I did want to tell you, one of the people listening wanted to thank you both very much, that they found it wonderful and enlightening. So just wanted to share that with you both. And, to thank you for your expertise and generosity. And so, yeah, we very much appreciate it.